Hi, this is Dr. Bhargava. In this short video, I have several interesting cases to share with you all. This is our first patient. They underwent a FDG PET-CT scan. Here is the rotating image, and the indication was tumor in the liver. And on the cross-sectional images, we find that there is a hypodensity in the right lobe of the liver that shows peripheral hypermetabolism, central necrosis, and there is a lymph node at the hilum that shows a similar finding of peripheral hypermetabolism and central necrosis. Now, pay attention to the liver. The surface of the liver is nodular. That suggests cirrhosis. And in cirrhotic livers, there are two tumors that can happen commonly. One is a more common hepatocellular carcinoma, which may or may not be hypermetabolic on FDG PET. And the second one is cholangiocarcinoma. And so this turned out to be a cholangiocarcinoma because on their multiphasic CT, which we are looking at right now, we have acquired CT in multiple phases. So pre-contrast, arterial phase, portal venous, and delayed. And we find that this tumor shows some contrast enhancement peripherally in a continuous fashion. And it slowly fills in from outside to inside over a period of time in such a way that on this delayed image, which is acquired 3 to 5 minutes after contrast injection, we find that the tumor seems to be getting smaller. And the periphery of it is sort of isodense to the surrounding liver. And this is a classic appearance of a cholangiocarcinoma, where in the arterial phase there is continuous enhancement peripherally, and then it slowly fills in over a period of time. Similar to hemangiomas, although hemangiomas would show nodular enhancement, which is discontinuous, and more intense enhancement on the arterial phase, and they will also fill in slowly, as opposed to a hepatocellular carcinoma where there will be uniform arterial phase enhancement, and on the delayed images we see washout and formation of a pseudocapsule. So this is a classic cholangiocarcinoma with metastatic disease to the liver hilum in a lymph node in a cirrhotic liver. This is a good review article published in Seminars in Nuclear Medicine, and although not on FDG PET, they are talking about FAPI PET, our new agent, and they say recent studies have demonstrated that FAPI PET CT provides superior sensitivity compared to contrast enhanced CT and FDG PET CT in cholangiocarcinoma and pancreatic cancer for detecting primary tumors, lymph node involvement, and distant metastases, particularly in hepatic metastases due to low physiological background uptake. This is our next patient, and they underwent a FDG PET CT scan for a suspected tumor or cancer in the left lower lobe of the lung. So let's start by looking at the rotating image. We find that there is physiologic distribution of the tracer, with the brain being most intense, then liver, and then the spleen shows mild uptake, variable uptake in the bowel loops, excretion from the kidneys into the bladder. And we don't see any focal hypermetabolism to suggest active neoplastic disease. And the cross-sectional images are showing this part in the left lower lobe of the lung, where we see classic appearance of rounded atelectasis. This is in the lung windows. We find that there's a part of the lung that appears rounded, atelectatic, and we find that the vessels and the airways are supplying this part of the lung, and we see that there is faint FDG uptake, which is physiologic. There is no focal hypermetabolism there, and so a tumor or a lung cancer has been ruled out. So rounded atelectasis is a common finding, incidental finding associated with pleural disease such as pleural thickening, calcification, or pleural effusion, and it may persist for some time, giving an appearance of a tumor. And in that situation, instead of putting a needle in trying to figure out whether there is a tumor or not, we can easily do a FDG PET CT study to look for focal hypermetabolism. All right, so this is a article that talks about the role of FDG PET CT in patients with rounded atelectasis, and they summarize by saying that in their experience, rounded atelectasis is not metabolically active on FDG PET, and so FDG PET scans can play a role in differentiating rounded atelectasis from malignancy when there are few or atypical features of rounded atelectasis on chest radiographs and CTs. This is our third and last patient for this video, and I'm showing you on this slide several images from an MRI of the abdomen, where starting with the T2 weighted image, we find that the In the tail of the pancreas, the parenchyma is atrophic and the duct is dilated. And this is a sign that there is proximal to the ductal dilatation a tumor, and the tumor is seen right here. And on contrast enhanced images, this is its appearance on pre-contrast. Here it shows arterial phase contrast enhancement, and then it shows continued enhancement on the delayed phase. And here in the bottom right, we have DWI image showing high signal and ADC image showing low signal. So putting everything together, we have a solid tumor in the pancreatic parenchyma at the junction of the body and tail, which shows arterial phase contrast enhancement. And so this is most likely to be a neuroendocrine tumor. The other solid tumor in the pancreas, which does not show arterial phase enhancement, is pancreatic adenocarcinoma, which has a much worse prognosis compared to a pancreatic neuroendocrine tumor. And so this patient underwent a dotatate PET CT to look for metastatic disease. And here is the rotating image, which shows physiologic intense uptake in the pituitary, some uptake in the salivary glands, spleen more intense in the liver, and excretion from the kidneys into the bladder. And we find that there is this focus of intense uptake in the pancreas, which corresponds to the tumor that we saw earlier, and confirms that this is a neuroendocrine tumor. And also it confirms that this patient does not have any metastatic disease, so they can undergo curative resection for this tumor. The other images are showing physiologic intense uptake in the left adrenal and also in the right adrenal. This should not be confused with a neuroendocrine tumor. Here is a related article, and in this review article, the authors say that gallium-68 dotatate PET CT is indicated for localization of the primary tumor in select cases, staging patients with known neuroendocrine tumors, and selecting patients for PRRT or peptide receptor radionuclide therapy. Thank you for watching.